Hello, everyone. My name is Stavroula Savelidis, and I'm the Executive Director of the Nassau County Medical Society and the Nassau Academy of Medicine. I want to welcome you all to our webinar tonight that will be focusing on vaccines. During the presentation, everyone's mics will be on mute. At the end, please feel free to raise your hand and pose a question or type one in the chat box. At this time, I'd like to introduce our guest speaker, Dr. Bruce Farber. Dr. Farber graduated from Northwestern University's honors program in medical education with a BS and MD. He then did a 3-year residency in internal medicine at the University of Virginia. After completion of that training, he spent a year doing a fellowship in the Hospital for Infection Control at the University of Virginia, followed by a clinical and research fellowship in infectious diseases at Massachusetts General Hospital and Harvard Medical School. He served on the faculty of the University of Pittsburgh Medical School and joined the staff of North Shore University Hospital in Manhasset in 1986 and LIJ Medical Center in 1996. He is currently chief of the Division of Infectious Diseases and the Jane and Dayton Brown Professor of Medicine at Hofstra Northwell School of Medicine. He has authored over 40 peer-reviewed papers, edited a book in infection control, and has written dozens of abstracts and reviews. Ladies and gentlemen, Dr. Bruce Farber.
Thank you.
You're on, Dr. Farber. Go ahead.
Yeah, I just don't see the slides.
Oh, I'm sharing them. They should be visible. You see them?
No.
Oh, that's odd. All right, let me share it again.
There we go. Okay, great. So I appreciate the offer. And what I plan to do is just give you an update in COVID and then focus on the vaccines. These slides were made less than 48 hours ago and everything has changed in the last 48 hours. So it's obviously a subject that is rapidly changing, and I will leave some time in the end for discussion. So I don't think it's any mystery to everyone that we are in another wave of COVID. And although New York's rates are slowly ticking up, the rest of the country is in the middle of a wave of COVID that really mimics what was happening here in April and in March. And it's horrible. It's totally uncontrolled all across the United States. And there's no question that when that happens, it will bleed into the communities that we live in. Next slide, please. So I can't help but just show you a few pictures of what is so clearly what happens in over and over again. And these are obviously pictures from 1917 and 18, when the worst pandemic in the history of mankind that killed more people than all of the other pandemics put together occurred from the Spanish influenza virus. And you will see that the more things change, the more they stay the same. And these are pictures, if I could have the next slide, of what the times looked like. There were people dying everywhere. The hospitals were overwhelmed. Next slide, please. This is a horrible picture of a mother dying with her child lying next to her. Next slide. And just look at the rates of influenza causing deaths in the community in New York, London, Paris, and Berlin in 1918 and 1919. And you can see that the rates were amazingly high, and that's not dissimilar to what's happening now. It should come as no surprise to any of you that COVID is now the third most common cause of death in the United States, second only to heart disease and cancer. Next slide, please. And finally, the same controversies existed over 100 years ago that exist now. Masks were worn. People were told that this is a highly communicable disease that can cause a severe pneumonia. And even though no one at that point in time had isolated a virus or knew what a virus was, which is one of the reasons why Haemophilus influenza is called influenza, because people thought that bacteria that were causing secondary pneumonias in people with viral pneumonia were the cause of the underlying disease. And that's how Haemophilus pneumonia got its name. Next slide. And of course, it was the same problem of closing down theaters, closing down schools, and history is repeating itself. Next slide. So let's talk a little bit about vaccines first. So all of you in this audience have received vaccines, and these vaccines are full of different platforms that you're used to hearing about. There's the live attenuated vaccines, that's the oral polio, the MMR, BCG, rotavirus, yellow fever, and chickenpox. And those are obviously live vaccines that have been made less virulent by the use of formaldehyde and other modulating chemical agents. There's the inactivated killed antigen vaccines, which is influenza, polio, hepatitis A, and rabies. There's the subunit purified antigen vaccines, typically the DTaP, Haemophilus influenza type B, pneumococcus, Prevnar, hepatitis B, shingles, and human papillomavirus. And of course, there's the few toxin inactivated vaccines, which just immunize against the toxin produced by the pathogen, and that would obviously be tetanus and diphtheria. Next slide, please. So none of those resemble anything that's being done with COVID. COVID, it's important for you to know, has a spike on the outside. That's how it got its name. Corona stands for a crown, and these spikes look like a crown. And that spike is bifurcated into two proteins. The first one, called S1, contains a receptor binding domain, RBD, and it mediates the attachment to the ACE2 receptor on human cells. In essence, this protein allows for attachment into the human when it's inhaled. The second is the S2 part of that, which is responsible for fusion to ensure successful entry of the virus particle into the host. This gene has been fully characterized and sequenced, and it was 42 days after the first isolation of the coronavirus causing this infection in China. Next slide, please. So what has happened? Well, there were over 120 vaccine attempts that were made. There are still 12 in active investigation, and there may be more coming. And they are all over the place, these vaccines. But I really don't have the time, and you don't want to hear about all of those vaccines. So let's focus on the 4 that are in the final stages of development in the United States and throughout most of the world, although, as I said, there are many others. And these vaccines are nothing at all like the platforms that I showed you that you're used to. Nobody has gotten these vaccines except for your dog who has gotten a viral vector rabies vaccine. And secondly, nobody on this call, but a very small number of people have gotten a viral vector Ebola vaccine that was developed after the big Ebola outbreaks in Africa. But for the most part, none of these vaccines have been used in large numbers of people. And how do they work? Well, let's look at them. First, follow with me, please, on the right-hand side of the slide. There are RNA vaccines. That is, of course, the Pfizer and Moderna vaccine that you've been reading about yesterday and today. And that is messenger RNA that is injected directly into the human. And that messenger RNA, as you know, codes for the production of a protein. And in this case, that messenger RNA codes for the production of that S protein that I just showed you on the surface of the coronavirus. The human we recognize that this protein is foreign. We make antibodies, and those antibodies should be active against that spike protein on the coronavirus and therefore infer immunity. Pretty novel, pretty cool, never been used before, and it's got some great advantages. Certainly cannot cause an active coronavirus infection. Secondly, should be pretty safe. It's just a small particle of an RNA, from the coronavirus. The other way of doing this, which is another vaccine that's active in Europe and is very similar, is a DNA vaccine. And that's simply taking, instead of messenger RNA to make the protein, taking DNA that codes for the production of RNA that we make, and then again, the same antibodies develop. So those are the two vaccines that we are going to talk about tonight, the RNA vaccines. But equally moving along at a slightly slower pace are the viral vector vaccines on the left-hand side of the slide. Now, the technology is different, but the outcome should be identical. What that is taking that coronavirus spike gene, the one I showed you, and incorporating it into either a replicating or non-replicating benign adenovirus. There are two vaccines that are in final phases of testing in the United States that I will show you. One is using an adenovirus from a chimpanzee, and the other is an adenovirus that has been used in humans. And those adenoviruses seem to be totally benign. They're injected into humans. The adenovirus does not cause any infection, but it quickly empties out that gene that has been incorporated into it that codes for that spike gene. And once again, antibodies are made. Now, if the science is right, it doesn't matter whether you use messenger RNA, DNA that codes for the production of messenger RNA, or if you use a viral vector to introduce the same genome that will make antibodies, because the antibodies that are going to be made with all of these vaccines are to that same spike protein that should produce immunity. And therefore, if one works, they should all work. Next slide. So most COVID-19 vaccines are using this technology that I've demonstrated. Yes, the Sino one from China is an inactivated vaccine that they are giving to large numbers of people. It's very similar to the Salk polio vaccine that was abandoned in the United States years ago. And no one knows very much about how effective those vaccines are. Until a large number of people have been vaccinated, the true toxicity of any vaccine will not be fully known. Next slide, please. So these are the finalists, the viral vector vaccines that are using two different adenoviruses, both very similar. They're relatively easy to produce, very limited experience, and the messenger RNA ones that you've read about in the newspapers. Both have been tested in humans. Both are relatively easy to make. You don't have to grow up a live virus or even an antigen in large concentrations the way you do, say, for flu. Even though the flu is an inactivated vaccine, the actual virus has to be grown up in eggs every year. There's no risk of infection from the vaccine. They have not been used previously, and all of them seem to cause a lot of local side effects. Next slide, please. So let's go through where we stand with these vaccines, and let me tell you a little bit more about them. So as I told you, if you look at the right-hand side of the slide, let's talk a little bit about the Moderna vaccine and the Pfizer vaccine that you've been reading about. Well, as I said, they're both very similar. What are the differences? The Moderna vaccine is covered with a small lipid layer. That's the only real difference. And both of these vaccines produce the same antibody, but because of that lipid layer, the Moderna vaccine is slightly more heat stable than the Pfizer vaccine. The Pfizer vaccine has been tested and has been shown to produce T-cell responses based on some pretty crude but reasonable tests of T-cell immunity. Now that's important because you remember that T-cells are the memory cells of your immune system. And if I got vaccinated or had measles, which I did when I was a small child, even though I've never been exposed to measles in many, many decades, there are T-cells somewhere within my immune system, whether they're in my lymph nodes, my spleen, my bone marrow, or in other cells, that as soon as measles is introduced into my body, they will wake up miraculously 50 years later and produce antibodies and protect me from getting infected again. And that's what we hope the T cells do for the SARS-CoV-2 strains. Now, what are the differences? Whoops, can you just go back for 1 second? Thank you. The vaccine for Pfizer, as you know, has to be stored in a cryogenic tank. The frozen vaccine can be stored in a regular freezer for up to 15 days, but it has to be packed in dry ice, and it can only be opened twice a day. It's not very forgiving. These particles of messenger RNA are very fragile, and they're easy to destroy. The Moderna vaccine, it turns out, can be used for up to 30 days once it's thawed out, and it can be stored in a freezer. So it's much more user-friendly. Regarding these vaccines, it seems pretty clear that the Moderna vaccine will be the point-of-care vaccine for physicians' offices, pharmacies, and rural areas. And the Pfizer vaccine will be used for inoculations of large numbers of people in places of employment, in schools, in health systems, in universities, in employment areas, because it requires a lot of work to get this vaccine up. It has a very short half-life of only 24 hours once it's thawed, and you have to have these cryogenic tanks and dry ice all over the place. So it's not going to be used other than in large places. Interestingly enough, both companies are happy about the fact that there's another vaccine, because the demand for these vaccines right now is so overwhelming that it will happen, and there's room for a lot of players, including the ones I'm going to talk to you about in a second. Now, let me just tell you a little about what came out yesterday and today. First of all, unbeknownst to me and most people, the Pfizer vaccine has contracts with many, many foreign countries. And so there's only going to be about 12 million doses of the Pfizer vaccine available before the end of the year, assuming it gets distributed before the end of the year. And it will probably be rolled out at a rate of between 10 and 20 million people per month, at least for the foreseeable future. The Moderna vaccine will not be ready until the early spring in the United States. Both of these vaccines have production problems. For example, just with the Pfizer vaccine, manufacturing boron-coated glass is a big part of this vaccine, because regular glass will quickly crack at those temperatures. Look on the left-hand side at the two viral vector vaccines. Well, the AstraZeneca vaccine is that one that uses the chimpanzee adenovirus. Initially, there was concern because they halted their clinical trials on September 6th. Within a week, they were restarted in UK, Japan, Brazil, and South Africa, and India. It took a little longer to start again in the United States, but they have started again. The Johnson & Johnson vaccine has one huge advantage. It's the only vaccine that is undergoing trials that is a single dose. All of these other vaccines require 2 doses. The Moderna vaccine is given at a 4-week interval, and the Pfizer vaccine is given at a 3-week interval. Neither one of these vaccines will produce immunity until at least a week after the second dose. So that adds another month or 5 weeks to the time frame of when you can be expected to be immune after you've received either of these vaccines. The viral vector vaccines can be stored again at regular freezers or at refrigerators once they're thawed. So they too are a little bit more user-friendly. Next slide, please. Now, I want to talk to you about how to judge the efficacy of a COVID-19 vaccine. You probably know that when you do an FDA controlled placebo trial, which is required to get FDA approval, you have to tell them upfront what is your endpoint. And you can never change that endpoint once you have enrolled your first customer into the trial. And it's kind of analogous to that you can't change the rules of the game or the goalposts after the game has started. Now, these trials have started with one endpoint, and that's that the prevention of infection, the total prevention of infection. No evidence of anything related to an active infection by any test that you do. And that is the gold standard of a vaccine trial and what was used here. But there are a lot of other outcomes that you could look at for a vaccine, despite the fact that you don't meet the gold standard. And that is already being demonstrated by the early results from the Moderna vaccine, which I will show you. And that is the following, that the vaccine may not prevent infection, but it may make somebody who's infected asymptomatic. It may not make somebody asymptomatic, but it may prevent hospitalization. It may not prevent hospitalization, but it may decrease your risk of winding up in an intensive care unit or dying or transmitting the disease to others, as is demonstrated on this slide. Now, this is important. It's important because although the preliminary results look much better than anyone anticipated, there are certainly groups of people as time goes on who are not going to be fully protected from this vaccine. But there's early hints, like the flu vaccine, that it will help down the line. How many people have told me over my career that I don't want to take the flu vaccine because I took the vaccine and it didn't prevent the flu? And I will tell them that's absolutely right, because the flu vaccine only works in a large majority of people if you're young and healthy in your 20s or early 30s. But if you're 80 years old and you take the flu vaccine, there's a really good chance it won't prevent the flu. But there's also a good chance that it will mitigate the flu that you get. And as I tell people, yeah, it didn't prevent you from getting the flu, but you didn't wind up in the hospital. Or if you winded up in the hospital, you didn't wind up with secondary bacterial pneumonia, or you didn't wind up on a ventilator. And so that's the advantage of looking at additional endpoints other than just the presence or absence of the illness. Next slide, please. Okay, so let's talk a little bit about the coronavirus vaccine that Pfizer came out with. Next slide, please. So first, let's look at the safety and immunogenicity of the Pfizer's COVID vaccine. Now, this looks at participants who were between 18 and 55 years of age on the top left-hand side of the slide, and on the bottom under it is participants who were 65 to 85 years of age on the lower portion of the slide. And then you look at the side effects after the first dose and compare it to the side effects after the second dose. And what you can see is, despite what you read in the New York Times today about the fact that everyone tolerated this beautifully, and they did, there was no serious side effects, there were a lot of local side effects. And look at the slide with me. You will see that particularly after the second dose of the vaccine, the side effects were substantial. Up to 75% of people got fever. Up to 80% of people got fatigue and chills. And after the first dose, the numbers were less, particularly with fever, but there was a lot of fatigue, a lot of chills, a lot of aches. And anecdotally, the people who were interviewed felt crappy, quite frankly, for 24 to 48 hours. Now, of course, that's a tiny price to pay for immunity to a disease that has destroyed our lifestyle and our way of living. But it is important to note, because people are going to need to be educated about this. And as you well know, we have a group of people, roughly 30%, who are, quote, vaccine hesitant, which is the new word that is used to describe people who are not 100% dead set against getting a vaccine, but are very hesitant and need to have their arms twisted and the like. And then you have a 20% of our population who are the anti-vaxxers. And these people don't want to take a vaccine, even if you are going to put a bullet to their heads. And they're adamant about this. And it is very difficult to change their minds. As a matter of fact, in many of them, you work on the vaccine hesitant group and you pretty much give up on the anti-vaxxers because they just are on a different wavelength with regards to this problem. Now, you know, I'm an infectious disease person. It's hard to get somebody more pro-vaccine than me in terms of me thinking that vaccines have improved the life expectancy of people and have prevented life-threatening infections, particularly in children, that were so common just 15 years ago that it's hard for me to relate to the true anti-vaxxers. But nevertheless, that is a fact of life. Next slide, please. So what do we know about the Pfizer vaccine? Well, we know on Monday, November the 9th, that Pfizer announced the preliminary results of their vaccine candidates where they found that the vaccine was more than 90%, they now say 94%, was effective in preventing any development of COVID. This, I still think, is a preliminary result. It's great and it's a good result, but it was done in roughly 20,000 people who were randomized, and the number of people who got COVID or didn't get COVID was still relatively small. The result was phenomenal. The FDA had set a bar of 50% efficacy for vaccine makers who wanted to submit an application for an emergency authorization. Flu vaccines are typically 40 to 60% effective at best. But I will compare it to an MMR, a measles vaccine, which have a 97% efficacy. Now, you will remember that herd immunity is dependent upon a number of factors, but under the worst case scenario, you will usually get herd immunity in the high 80s or 90s. So when you have a vaccine like measles or a vaccine like COVID that really produces 95% efficacy, herd immunity will follow and the outbreak will literally disappear. So as you know, Pfizer has plans to ask for FDA approval for emergency authorization of their 2-dose vaccine later this week or month, but very soon. They have collected 2 months of safety data. That is enough in the United States to ask for an emergency authorization. It is not enough time to ask for authorization in Europe, where they are going to require at least a 3-month follow-up. Again, looking for side effects that were not immediately apparent during the first 2 months. Pfizer has recommended that thermal shippers not open more than twice a day. And what they have also done, which is going to be linked to Northwell's product, is pretty cool. And that's that there is a GPS device on every shipment, on every pack, not just shipment, that will link to every group of vaccines that are opened. And Tiberius is a tracking program that will link and show which group of vaccines you got, where it came from, how it was delivered, where it was stored, did the temperature cycle ever break for any length of time? Was it, thawed, for example, and not good? And lastly, who got the dose? And so this will be extraordinarily helpful in a very complicated logistical rollout, because after all, we're going to need to know who got the first dose, where they're getting the second dose. We have to guarantee people that if they got their first dose, they can get their second dose. The vaccine is not good if you don't get 2 doses. And interestingly enough, you're not going to get immunity until at least a week after the second dose. So whatever timeline we're looking at, add a month or 5 weeks to that timeline, because you're not going to be immune until 5 weeks after that second dose. Next slide, please. What do we know? Well, we know from their early trial that it looks great. But once again, caution is important. And in order to know the real extent of the effectiveness in immunosuppressed patients, in nursing home patients, in people who are on immune modulating drugs, it has to be given to really large numbers of people. Who's going to get the Pfizer and Moderna vaccine first? Well, the final decisions are being made by the committee that advises the CDC on immunization practices, but I certainly have seen their recommendations. And the first two groups to get it are going to be healthcare workers on the front lines with face-to-face, showing face-to-face with patients. And the second group will be elderly people, particularly those with comorbidities. And so these are the two groups that will get rolled out first. What's left to be done in the Pfizer trial? Nothing. This slide was literally made on Monday and the trial was concluded yesterday. So the trial is over. What about children and elderly? Well, Pfizer just opened up a new trial that is undergoing recruitment now to include teenagers and children as young as 12 to determine if the vaccine will work in children. As you know, this virus really does spare, to a very large extent, children under the age of 10. Out of the 200 and close to 50,000 Americans that have died of COVID, roughly 120 of them are children. And if you look at those people, over 80% of those children had comorbidities. And young, healthy children under the age of 10 that have died have been in the 2-digit numbers. Now, that's not to say that it can't happen, but nevertheless, this virus has not been spreading and being spread by young children. That's totally different, of course, than teenagers and young college students who are a major vector of the spread of this. That's why I personally feel that it is not fair to children to close elementary schools and treat all children the same and close all schools or have them all open. It's not the same virus in these different age groups. How long will your virus protection last? No one knows. Paul Ott, one of the FDA people, said it's reasonable, but still a gamble to suspect that it will be at least 6 months to a year. Quite frankly, I think and hope that it will be a lot longer. Next slide. I guess I want to go through a couple of other things regarding this vaccine before we talk about travel a little bit and opening this up. And that's, I want to tell you a little bit about the way the vaccine is going to work. Now, I never really appreciated what an emergency use authorization was until COVID came around. I guess they were around, but now they're around every week or two. Remdesivir, hydroxychloroquine, practically every COVID test you are using now is an emergency use authorization. Today was another one, the first home test. Now, what is an emergency use authorization? Well, of course, it's a law that allows for the use and widespread use of a product or a vaccine that allows for it to be used before it has been FDA approved. So realize that none of these COVID vaccines have been FDA approved. And even after they get their emergency use authorization, they are not FDA approved. So what is the distinction? Well, there is a distinction. First of all, it does not require informed consent to use an emergency use authorization. What it does is it requires you or the healthcare provider, the physician, or who's ever giving the vaccine, to give people an information sheet that tells them that they're basically taking an experimental non-FDA approved vaccine. Most people aren't going to care if they think it's safe. But again, we have 50% of our population that are vaccine hesitant or anti-vaxxers, and that's not going to help. Secondly, it requires at least 6 months to get FDA approval. We only have 2 months follow-up. Europe's requiring 3 months follow-up. So once again, people are going to be nervous. how do you know that this vaccine is not going to be recalled 2 months from now when we find out that there's some unusual side effect to it? That has happened repeatedly with vaccines. I personally took a smallpox vaccine about 15 years ago, and within 2 weeks of taking that vaccine, it was withdrawn from the market because it caused a high incidence of pericarditis that was often fatal. That also happened with the 1976 swine flu vaccine. That happened with an early rotavirus vaccine for infants. That happened with dengue vaccines. So it's not inconceivable, and you have to keep that in mind when you are evaluating this vaccine. I think I'm just going to actually tell you just a couple of quick things about travel before opening this up to questions and answers. And if there's other questions about COVID, I am happy to address them. So as you know, we are in a horrible situation in the United States. And just to very briefly change subjects, the virus is spiking all over the place. New York's rates are quadruple what they were for 4 weeks ago. And New York City schools are going to close. I think that's a mistake, particularly at the elementary schools. And I urge you not to travel and to double down on social distancing and being careful, because if these vaccines really are even closely or remotely as good as has been demonstrated in the last week, that the end will be in sight and there will be a dawn, even though they're in the darkest period yet. So if you are going to travel, I want to just tell you a couple of things that I think are becoming increasingly clear. First of all, that your risk of getting COVID on an airplane is actually very small. I have no trouble getting on an airplane. The air that's recycled in an airplane does go through a HEPA filter. It's very similar to the air you breathe in the best parts of our hospital. And people are not going to get COVID all over the plane because somebody in the back has COVID. You are at risk from getting COVID in the airplane only from the people who are sitting directly next to you or directly in front of you or behind you. So if you're going to go, you're going to wear a mask. And secondly, you turn on the air valves of that airplane, which produces excess airflow and decreases the risk of you getting infected from an individual sitting next to you or in front of you. There have been 42 well-documented cases of COVID that have occurred in commercial airliners to date. Now, it's hard to do good surveillance, and there may be quadruple that number, or there may be 10 times that number, but there's not huge outbreaks that have been related to travel. There's huge outbreaks related to super spreading events every day, and that's inside, poor ventilation, closed windows, and people talking, eating without masks, but not in airplanes. So that's the good news. The bad news is be very careful in cars. These have been shown to be much higher risk, particularly, obviously not in your own car, but in ride-sharing apps and cabs. If you're going to do it, or you have to do it, have the windows open to improve ventilation, and do just the opposite of what you're going to do in an airplane. You turn off the air conditioning in the summer, and you turn off the fans that are blowing hot air in the winter, because they are going to increase the risk that your driver who might have COVID will spread the infection to the back of the car. So as cold as it is, try to keep the windows open, and certainly in the summer, keep the windows open. I think that I will stop there, but I have time for a lot of questions, more time than I anticipated. I will just end on the following note, that Northwell, which I work for, is being very, very aggressive in opening up pods and will work closely with the state of New York in addressing the rollout of the COVID vaccine. It is actually going to be a Herculean task, particularly with the Pfizer one. We are going to be partnering to open up multiple locations, particularly in lower socioeconomic areas where this vaccine will be given. We will also support our healthcare workers, whether they are full-time or voluntary. And that will be a big, big effort and will take weeks of work. Secondly, effective Friday, we are opening up our first center for the injection of the Lilly monoclonal antibody in South Shore or South Side Community Hospital. The second one will open up shortly after Thanksgiving on North Shore side, and another one will open up in Westchester. I urge you to refer your patients to these centers. This product is being given free of charge, as, by the way, as will the vaccine. There won't be a charge for it. And this is a very encouraging product that has to be given to people who are not in the hospital. You cannot use it by emergency authorization to people who are hospitalized or on oxygen unless they were previously on oxygen for COPD or some other chronic disease. And it is given, and it significantly, by about 75%, decreases the risk that you will go into the hospital if you are given the monoclonal antibody. You need to give it as soon as possible, ideally within 72 hours of the diagnosis being made. But by law, I think you have up to 10 days to do it. And we will have the ability to give it to about 20 people per day. It's not a huge amount, but it's not nothing either. After Thanksgiving, it will be open 7 days a week with the exception of Christmas and Thanksgiving. And you will be able to refer to it through a call-in number that will be opened up on Thursday. I don't have the number, but it will be available online starting on Thursday. The care of the patient will not be assumed by any of these infusion centers. So their main job is basically, not their main, their only job is basically going to be to give this monoclonal antibody, watch the patient for 2 to 3 hours. There will be physicians to watch them during that period of time, but the care of the patient will go right back to the physician. They don't have the ability, the desire, or the resources to take over any ownership of all of these COVID patients that go there. So just keep that in mind if you refer a patient there. I think I will stop and open it up to questions a little sooner than I thought. Thank you.
Dr. Farber, we had a couple of questions emailed, so I'll start with those, and then there's a few in the chat. So the first one is the vaccine recommended for patients who already had COVID?
The answer is yes. We don't know how long your immunity with COVID will last. It is too difficult to screen for antibodies before undergoing a massive vaccination program. And so the answer is no one will be screened. Obviously, if you've had documented COVID, you're a lot less likely to get it again, at least for sure for 4 months. So it's up to you, but nobody's going to screen you, and you're certainly welcome to get the vaccine.
Okay, and the second question is, when will the vaccine be distributed to physician offices for distribution? I think physicians will be better able to convince patients to receive the vaccine in the office and then administer it, rather than relying on skeptical patients to take the initiative to go to a pharmacy for a vaccine.
I couldn't agree with you more. I think there's good data that I didn't go into and didn't have time that demonstrates that when you look at the people who are skeptical about the vaccine, you find that 80% of them, 80, don't trust the government. And 50 to 60% don't trust anyone other than their physicians. And so I couldn't agree with you more. To get vaccine hesitant people, they need to trust a physician. So when you asked when we'll get it in the office, unfortunately, you're never going to get the Pfizer vaccine in your office. It's just not logistically possible. And you will get the Moderna vaccine in your office, but it's probably not going to happen until the late spring. I mean, that's what they're saying now. If they beat that target, that's great, but I don't think it's going to happen until the late spring.
Okay, thank you. Next question, didn't adenovirus cause problems in the gene therapy study a few years ago? Why won't that be risky now?
Well, that's a great question, and I'm not sure I have a great answer to it, other than that these two adenoviruses that they looked at were not the same that caused problems before. And that's why we need to see those studies before I am comfortable in telling you that you don't have to be worried. I'm still worried. I'm still worried with only 2 months follow-up, even with the messenger RNA. And I certainly will still be worried with the adenovirus, particularly since those studies were halted and restarted. So that's a legitimate question, but I don't think we have the answer yet.
Will the vaccine be safe to give in patients undergoing chemotherapy and other immunosuppressive therapies?
Yes, that will not be a contraindication. After all, these vaccines are not live, and people undergoing chemotherapy and who are immunosuppressed need it more than healthy young people. And that's why the target groups are going to be elderly people with comorbidities. So yes, nobody will be screened for immunosuppression, and it will not be a contraindication. And that's one of the great benefits of this new technology, and hopefully it'll be applied to other vaccines.
Great. Are there any other antivirals oral that are on the horizon?
No, not that are really good. No. There is a outpatient remdesivir trial that we're participating in, but it's mediocre. And the answer to the question is really no.
Okay. What should PCPs know to monitor for inpatients who receive the antibody?
The antibody, again, it's an emergency use authorization, but it is a monoclonal antibody. The side effect profile is similar to other monoclonal antibodies that many of you have used in your practices, analogous to Remicade and other drugs like it. It's very sort of similar. In terms of monitoring, it would really be mostly for the COVID to get worse. There's some local problems, but to date, there has not been any serious toxicity from the monoclonal antibodies. But again, the follow-up has been short. This is not FDA approved. Everyone should not confuse an emergency use authorization with FDA approval. And even FDA approval, which is a 6-month process, is no guarantee that you're not going to see side effects that appear later. I mean, there's no comparison of giving a vaccine to 22,000 people in each arm of those two groups, roughly, compared to giving it to 100 million people.
Recognizing that Pfizer has already committed vaccine deliveries to other countries, how many of the 25 million doses will actually come to New York?
I don't know the answer to that. That is currently in the hands of the federal government, and that is a very politically charged question, as you well know from reading the newspapers. I do think we're not going to be the first online. And I think you know that. The governor is constantly, of California and New York, are fighting with the current administration about the distribution of the vaccine. So I don't know the answer.
When do you anticipate the Moderna vaccine be ready?
Well, I don't think it's going to be widely distributed, according to the company, until the spring. There may be some doses that flow sooner, but they're having trouble ramping up. It's an enormous project to make millions of doses. And, you know, it's relatively easy to make thousands. It's really hard to make millions. So I think realistically, the early spring, late winter.
If given to someone who had COVID, can you get an exaggerated adverse response? Has this been looked at in vaccine trials, or is recommendations to give people who already had COVID based on increased desire to vaccinate the community?
Yeah, I mean, that has clearly happened in early dengue trials with the dengue vaccine. It has not been demonstrated. It's called antibody enhancement, and it is a theoretical concern, but it has not been demonstrated in these vaccines. And they have looked for exacerbation of COVID in the trials. So I don't think that that's going to be a problem. And I do, as I said, no one's screening for antibody. And that's not part of any of the protocols. And as you know, in New York, I mean, as sad as it is, antibody levels are up to 20% in some of our communities. So it's not going to be that uncommon for somebody to have had either asymptomatic COVID or symptomatic COVID and then get the vaccine. but I don't anticipate that that will be a problem.
What patient population is appropriate for monoclonal antibody? All patients with early infection?
No, let me give you the basic guidelines. It's also based, and it's not open to negotiation. These were the rules of the Emergency Youth Authorization, and people will stick to them, including our centers, very closely. And they go, and you'll get this a sheet on it, but in short order, it's going to go something like this. Anyone over the age of 65 is eligible. Anyone over the age of 55 with one of three comorbidities will be eligible. And people between the ages of 12 and 17 with comorbidities will also be eligible. Under 12 will not be, and over 17 will not be eligible until they get to the age of 55.
Any other questions? Okay. In closing, Dr. Farber, unless there's someone who would like to, oh, here we go. Oh, this was great. So Dr. Farber, in closing, what would you like to?
I want to just tell people, there's two more quick questions.
Okay.
What happened to the Regeneron monoclonal antibody? It's out there. It's a cocktail. And the reason why it's a cocktail, which you heard about, because the president received it, is because unlike the Lilly monoclonal antibody, which is directed against only one of the components of that spike gene, that I showed you, it is a monoclonal antibody to both of those components, S1 and S2, and it's coming. I think it will show up within the next 2 months. They're anticipating asking for emergency use authorization soon, and I think it will help because we're going to need both of them. And secondly, please check the inclusion criteria that will go out with the information about the candidates for the monoclonal antibodies, because I did it from memory and they may be slightly different in terms of which specific comorbidities are allowed in children and in younger adults with many comorbidities.
Okay. There's another question that came in. Can you please repeat what you said about people between 18 and 55 getting the vaccine?
Oh yeah, they'll be eligible between 18 and 55. They are eligible for the vaccine, absolutely.
Okay. And do you think hospitals will surge as they did in the spring?
Well, it depends on your definition of SIRS. I can tell you at North Shore where I work, we had 9 COVID patients in the hospital about 5-6 weeks ago. We now have 40 some odd. There's no question that the number is increasing. I don't think it'll ever get up to 700 because I think there'll be massive lockdowns in New York. I can't speak to other states because the politics are intense, but we can never get back up to 700. We can increase that number up to, a sizable number without having to shut down elective surgery and all the normal things again. And so hopefully it won't get that bad. But quite frankly, I don't trust this virus, and stay tuned because my prediction is not a lot better than yours.
And one final question, is Moderna's reason for being delayed strictly making the amount of the vaccine?
Yes, it's strictly manufacturing problems. It is difficult. And yeah, they'll probably put out thousands of doses in the interim, but we're not counting that because, you realize that you need 2 doses. So we're talking about 600 million doses to vaccinate most of the United States, or in that neighborhood. And that's a lot of vaccine, 600 million doses.
And we'll wrap up with this. Which vaccine would you take or prefer?
I'm not taking either yet. I still want to see the data, but I can tell you that I would take either the Pfizer or the Moderna vaccine. To me, they are Coke and Pepsi. As long as they're stored properly, they're virtually identical vaccines. And, it's always risk versus benefit. And I can't swear to you what the safety outcome of these vaccines will be after 100 million people get it. But I think what we do know is this is a deadly virus, and it is, killing. I mean, look at the numbers. 1,500 Americans a day are dying from this virus. So the risk-benefit ratio, at least at the present time, seems overwhelming. And I can't wait to get a vaccine to get out of the mess that we're in.
Wonderful. Thank you so much, Dr. Farber, for your time and for your insight. I think
You're
this was
welcome.
very informative. This recording will be available. There were more slides, with a little bit more information from Dr. Farber, so you could definitely look at those. And we want to thank everybody for participating tonight, and we look forward to better news as time goes by. Thank you all very much, and enjoy your Thanksgiving coming up next week. Be safe.